the next is about the tumors related to the uterine structure as such, and among them, the one of the important condition is the gestational trophoblastic disease or hiatus form mole. Now, the gestational trophoblastic disease is a nomenclature given to a group of disorders where there is a abnormality of the placental structure, and that results in maybe a malignant condition. That condition is called as gestational trophoblastic disease. Out of this, the hereditary form mole forms the most significant issue. Placental site trophic tumors, trophoblastic tumors, and choriocarcinomas, they are very few in number, and rarely we see such patients. Some of the times the hereditary form mole may progress into a choriocarcinoma as such. Now, the moles, we will give more importance to the moles or molar pregnancy or hereditary form mole, and others of course we will just casually refer to. Now, hereditary form mole or a molar pregnancy is again categorized in two categories, complete and partial. A complete mole contains no fetal tissue. It's mainly due to the abnormality of the chromosomes. I will come to that part, like how that chromosome abnormality are there. If there are both the X chromosomes and then that progresses in without having that diploid structure, then it's the 46 XS. Or if the same has a XYY, that's two of the male gametes are there, then that's the male chromosomes are there, then that's the other way. So there could be two varieties. That's what we call as the complete mole, where there is virtually no fetal tissue. It's only the placental structure which is abnormal, which is having some flower-like or leaf-like projections. That is this situation in case of the complete mole. Whereas in a partial mole, fetal tissue is present, and fetal erythrocytes and vessels as well as some of the structures are seen as such. At times even there could be a twin pregnancy, like one normal tissue and then another molar structure. So that's the partial mole. But majority of the patients whom we see are complete moles. And again, complete moles are classified further into androgenic and heterozygous based upon the chromosomal structures as such. The classification of the hereditary form or molar pregnancy again as complete or partial or invasive mole is which results in the choriocarcinoma later. Gestational trophoblastic neoplasms again further are categorized into choriocarcinoma or placental site trophoblastic tumor as such. Then there is one more condition called as tumor-like lesion, which is a placental site nodule. But these are very rare conditions. All that the majority of the patients whom we see are in the molar pregnancy, where you have complete, partial, or invasive. The differences between these are in the particularly complete hydatid form mole, it's having large avascular villi projections with the trophoblastic proliferation. And clinically, it occurs when a fertilized ovum contains only paternal chromosomes, that's XX chromosomes as such, and maternal chromosome is not added on. That condition is the androgenic, and it produces uterine enlargement, and the whole of the placenta would be fragile, and it's only the fragile which is seen, no fetal tissue is seen, and that kind of appearance is called as snowstorm appearance in the ultrasonography and may result in choriocarcinoma. Partial hereditary form mole is where some villi are enlarged with the trophoblastic proliferation, some projection as such, and they are having chromosomes of either triploid instead of, see, normally there will be haploid gametes which results in diploid embryo. In these conditions of partial hereditary form mole, there could be a triploid, that's three chromosomes, set of three chromosomes, XXX or XXY or XYY. All these could be seen, and it may result in a malformed fetus. Some of the fetal structures could be seen in ultrasonography. Choriocarcinoma is a malignant proliferation of the syncytotrophoblast with no villi. There will be no villi as such, and often produces hemorrhage, and no fetus is present. And human choreographic choreogonadotropin hormone levels are often extremely high, and it can produce metastasis, and it is sensitive to chemotherapy. So choriocarcinoma is the real malignant disease there. Then the other placental trophoblastic tumor is a rare localized proliferation which is comparatively rare, and most are benign and some are malignant diseases. Placental nodule is a rare proliferation of intermediate trophoblastic, which is microscopic also, no major consequences. Now the pathology of the moles, hydatidiform mole, complete and partial, is in the normal situation. The two haploid gametes, male and female, they merge together to form a zygote which would have the diploid structure. That's X and Y, both of them, the contributions from both would be added on, and hence there will be either XX or XY structure. Now, if in a complete hydatidiform mole, the sac would be that ovum, either it could be, ovum may be empty, and the male gamete, that's 23X chromosome, may just add on and multiply their duplication, which results in a diploid XX chromosome. Or it could be like there could be a one female and one male gamete together, which may add on, like rather two of the male gametes, they will be add together, which results in the XY configuration, 46XY, which may be present, and these are considered heterozygous. Whereas androgenetic is where there would be only the male gamete present, no female gametes, that results in 46XY. In partial hydatidiform mole, there will be triplicity, where more than one male gamete would be merging together to form the zygote with the ovum, and ovum is not empty. Now, in case of a complete hydatidiform mole, the ovum would be empty, it is only the chromosomes from the male side they are added on. Whereas in the partial hydatidiform mole, the chromosomes from the ovum as well as chromosomes from the male gamete are added, but there will be more than one male gamete added on. This kind of abnormality of the fertilization process results in the pathology of the hydatidiform mole. Incidence of hydatidiform mole is estimated to be between 1 to 2 per 1000 pregnancy, whereas in India the rate is considered significantly higher, around 160 pregnancy. Now, the reasons why it's more common in India compared to elsewhere, that is not known. The real reasons are not known, but we have the statistics, and the number is increasing every year. If you see the incidence, the number is increasing. And the other way of description of partial or complete mole is the appearance as such. The partial mole, there would be a mass which is having a part of the uterus occupied. Complete mole is a larger mass. Invasive mole, that mole which penetrates into the myometrium. Choriocarcinoma is which produces metastasis. Appearance would be, in a complete mole, you will have fragile tissues with different grades of this vascularity. Either there could be a pale whitish structure, grape bunch-like appearance, where there will be very minimal blood flow, or there could be maximum blood flow also, fragile with the vascularity. Whereas a partial mole, there will be some partial fetal structure, either a complete fetus or some of the structures of the fetus would be seen along with that fragile placenta. That would be the appearance. The clinical symptoms are mainly the vaginal bleeding. The most common symptom would be more than 50% of the patients would have the vaginal bleeding after the fertilization. So once the patient is confirmed to be having a fertilization, then after a certain period of time, it could be at any time, but most of the times the symptoms would occur within the first trimester, that's within 12 weeks the symptoms do occur, and it could be presented with either bleeding, or due to the collection of the blood, the uterus may become distended. and it may leak into the vagina, and that's how the patient may have vaginal bleeding. Or there could be hyperemesis. It's also seen in around 4% of the patients diagnosed at 5 to 9 weeks of gestation, and in 23% when the diagnosis is made after 10 weeks of gestation. So delayed diagnosis, the hyperemesis would be more common. Another common clinical symptom would be signs of hyperthyroidism. Hyperthyroidism like palpitation or tachycardia, weight loss, extra soreness, they do occur, and it's seen in 3 to 3.7% of the women with head-headed mole diagnosed after 10th week of gestation. That's also another issue. The delay in the diagnosis produces more symptoms, and partial mole patients may not have the same clinical features as those of a complete mole. These patients usually present with the signs and symptoms consistent with the incomplete or missed abortion. That may be a history suggestive of missed abortion, including vaginal bleeding and absence of the fetal heart sounds as such. Other clinical signs which are often considered to be a possibility of a hydrated mole in a pregnant woman would be a size which is not corresponding to the gestational age. You have standard parameters like what would be the size of the uterus at each week in the obstetric practice. That is one of the criteria to assess whether the pregnancy is progressing properly or not. Now, if the uterus size doesn't go along with that chart which we usually use, either it could be more or lesser. So most of the times it could be much enlarged. The uterus would be more enlarged due to collection of the blood and the increased mass size of the hydrated mole. But at times it could be even smaller than the expected date as expected gestational age, because at times it may result in shrinkage. After the bleeding, there could be shrinkage as such. The other clinical symptoms which could be seen is preeclampsia, where the patient may have eclamptic symptoms, but the incidence of the eclampsia due to hydrated mole has become reduced significantly, because most of the times the patient would be diagnosed of mole because of ultrasonography. Now these days ultrasonography before the end of first trimester has become almost a rule. So almost every pregnant woman would undergo ultrasonography, and hence they would be diagnosed beforehand, and before the eclampsia would be seen, the diagnosis will be done and the patient would be handled, and hence the patients having history of preeclampsia in case of hydrated mole is seen very low, and it is limited to around hardly 2% of the total cases. There could be a twin pregnancy, as I told, which may look like normal, and this twin pregnancy with mole is always a very difficult issue to handle, because the other issue or other fertilized this gamete may look normal, and it may be even progressing well. The size also would be of the fetus would be growing well with normal fetal heart sounds also. And in such condition, whether to go for termination of the pregnancy or whether the patient has to continue with the pregnancy would be a sensitive question. But as there is a high risk of penetration and metastasis, it's better that termination of the pregnancy is done even if the other fetus seem to be normal. This is the standard guideline. Investigations would be the most important investigation when you suspect the molar pregnancy would be the HCG levels. Chorionic gonadotropin hormone levels have to be done, and usually in majority of the patients it would be higher than 1 lakh microunits per milliliter, and they suggest about the trophoblastic growth, and they suspect about molar pregnancy, and that is now a routine investigation. Now once the conception is confirmed, HCG level confirmation also is one of the routine investigation along with the ultrasonography, and hence the diagnosis now is made bit early. The other is the anemia. Anemia could be present, and the patient also may have coagulopathy. The clotting would be abnormal. Abnormal clotting time also could be seen. And the investigations also should about the clotting function studies, the clotting time. Thyroxine level is one more of the routine investigations which is done again in almost every pregnant patients in the standard protocol of dealing with the obstetric patients. And prenatal assessment, thyroxine level assessment also is one of the issue. Ultrasonography is one of the important criteria to identify both complete and partial molar pregnancy. Most accurate diagnosis would be done by ultrasonography or other imaging studies. Of course, ultimate would be histology. If at all the tissue is removed and the tissue is subjected to histopathology, that confirms the diagnosis. Some of the patients may not be diagnosed with the mole in the initial stage, but there could be a typical presentation of the ovarian cyst, which is also called as fecal lutein cyst. That fecal lutein cysts are different from the routine, the distension cysts of the ovaries, because they may have a diameter of greater than 6 cm in diameter, and along with that there would be ovary also would be enlarged, and they are not usually palpated by manual examination, and they may have pressure on the vessels, pelvic structure, and hence the patient may have a pelvic pain. And as the size is increased, there is a risk of torsion. So some of the patients of hydatidiform mole may present with the ovarian mass cyst, which is also called as fecal lutein cyst, which is somewhat different from the usual distension cyst as such, and they are reported in 11% of the cases where the mole persists for more than 10 weeks. The typical ultrasonography presentation would be in a normal pregnancy by about before the first trimester, the area of embedding is seen and the uterine cavity is seen, myometrium is clearly seen. Whereas in case of a mole, complete hydatidiform mole, you will see many of these tissues, snowstorm appearance is seen with the multiple areas. So in the normal, there will be clear gestational sac with the well-defined fetal pole where you can make out the direction of the fetus, and the echogenicity would be uniform, and the growth would be consistent with the gestational age. Whereas in patients of hydatidiform mole, there would be a snowstorm appearance with multiple small lesions, cystic spaces around, and the uterus may seem to be larger than the usual, and no visible fetal structure. This is the typical appearance in ultrasonography in a case of mole. And in general, because of this ultrasonography culture, the total this incidence of moles, they resulting in complications, clinical complications are lesser, because almost every case is diagnosed in the first trimester itself, and suitable handling is done. The other way, when you look at that complete hydatidiform mole in the longitudinal view, again the same appearances are seen. So with the ultrasonography image, it can be made out. Treatment, the ideal treatment is evacuation of the uterus by dilatation and curettage is always necessary. DNC and evacuation is necessary. And to evacuate or to induce that expulsion of the products of fertilization, prostaglandin or oxytocin injection is not recommended because it may result in increased bleeding and malignant sequelae. One of the important complications which often can occur when you deal with the hydatidiform mole is respiratory distress can occur at the time of surgery, and this may be due to the embolus formation. The trophoblast may get embolus, and it also can result in congestive heart failure due to anemia. Once the evacuation is done, the patient has to be followed up to rule out the possibility of a metastasis in such patients or recurrence of these neoplastic changes. And to follow up that, HCG levels are to be done, serum HCG levels have to be repeated weekly for 3 to 4 weeks, and the levels should gradually drop. So if the levels do not drop, then there is a possibility of developing this metastatic disease, and there the patient requires chemotherapy. Otherwise, it doesn't. A simple hydatidiform mole After evacuation, if there is a gradual progressive HCG level reduction and it has reached normal levels within 8 to 12 weeks, then there is no need of any follow-up as such. There is no need of any other intervention. If the HCG levels are flat or they raise, then it has to be considered as a malignant disease and it has to be treated with the chemotherapeutic drugs. Once the patient has a hydatidiform mole, in the next pregnancy, chances of developing the mole is also high. It's around 1.2 to 1.4%, and the risk increases to 20% after episodes of 2 of these moles as such. Prophylactic chemotherapy after evacuation of a hydatidiform mole is not routinely recommended. Now that's why I said only that HCG follow-up is necessary. Chemotherapy is not required. Only if the HCG level doesn't come back to the normal by 12 weeks, then a chemotherapy is required. And certain of the people, they may be recommending a prophylactic chemotherapy even if without bothering about these sequences, but now it is confirmed that it is not needed. Only 20% of the men in the hydatidiform mole will develop malignant sequelae. That's about the hydatidiform mole. Now the last part of this gynecological oncology is the uterine fibroids. Now fibroids is also called as leiomyoma, is usually a benign tumor. 99% of these conditions are benign tumors, and the benign tumors of the uterus, benign tumors of the fibrous tissue can occur in any part of the body. Of course, if at all you look at the incidence of the leiomyoma, the number of cases having leiomyoma in the subcutaneous tissue are much higher. The uterus is the next part, but because we are dealing with the uterus issue, we refer to the uterine fibroids as one of the clinical condition which has some significance. Almost majority of these are a benign condition, and they are classified based upon their location, and the classification is either submucosal fibroids, where the location is just below the mucosa. When it is below the mucosa, it can affect the fertilization or embedding of the uterus. This fetus also could be affected in such conditions, and they are very close to the endometrial cavity, and they may even present with the heavy menstrual bleeding also. Submucosal fibroids, they tend to produce increased chances of heavy bleeding, as well as a improper embedding which can result in miscarriage or incomplete pregnancy conditions, or even it may even result in a progression and further prolapse through the cervix also. Then intramural fibers are those fibers which are below the mucosa but within the myometrium, and they usually grow within the uterine wall, and they are presented with a mass effect where the abdomen may become distended, and patients may have urinary frequency due to bladder compression. Intramural fibroids, they tend to press upon the bladder, and hence the patient may have urinary symptoms quite frequently. Subserosal fibroids are on the exterior, that's very close to the serosal surface, and even they may be pedunculated, like having a pedicle-like structure, and they are associated with again bladder compression and abdominal distension. Chances of bleeding are lesser in such conditions. Incidence of the uterine fibroids is again globally varying. India is one of the areas where the incidence is quite high. The percentage of incidence of fibroids in India is quite high compared to the other countries, and again the reasons are not known, and it's also true that the incidence is increasing every year. Compared to every year, the incidence of fibroids is increasing. It's supposed to be due to the abnormal lifestyle habits like the risk factors which are known are the obesity is one of the known risk factors, and age in which the patient gets fertilized, delayed pregnancy or nullipara, having no pregnancy, also is supposed to be one of the causes. Then exposure to the chemicals, particularly the malignant inducing chemicals, also is one of the other known causes which are variable causes, and vitamin D deficiency also is attributed to be a cause for the fibroids, as related for the fibroids. Of course, race Another is issue, pigmented races like Indian, Africans, they have a higher chances, whereas the Mongoloids also have a higher chances of developing this fibroid issue as such. The whole process is a gradual process which starts with the DNA damage, modification of the DNA, and at the end it can result in a mild inflammatory changes in the cells, and then results in a benign mass, tumor mass as such. The clinical presentation would be, most patients are asymptomatic. Most of the times it's discovered during some other routine gynecological examination or maybe ultrasonography. Presenting symptoms may be following, like the most again would be common would be abnormal uterine bleeding. Abnormal uterine bleeding, either it could be excess of bleeding during the cycles, or in between the cycles there could be the bleeding, or the total duration of the cycles also could be episodic, like irregular bleeding occurring also can occur in such patients. Pelvic pain due to mainly the degeneration, tissue degeneration or torsion, which may present as acute pain or the spasmodic pain due to the contraction of the uterus. Pelvic pressure symptoms may result in edema, pedal edema, urinary frequency, or at times constipation. These also can occur as the symptoms due to the pelvic pressure. But comparatively they are rare. The other symptoms could be abdominal distension, and the patient very often may have genitourinary dysfunction, which may present as increased frequency due to bladder compression and pain due to the ureteric compression or even hydronephrosis. Infertility also could be one of the presentations, because particularly if it is submucosal or as such. The FIGO classification is into 8 types. Type 0 is pedunculated intracavitary, type 1 is where it is more than 50% intramural, type 2 is less than 50% intramural, type 2 is when it is more than 50% intramural, type 3 is 100% intramural, type 4 is there is no connection with the endometrium, it is purely intrametrial, and similarly type 5 subserosal less than 50%, type 6 is subserosal more than 50%, and type 6 is subserosal less than 50% intramural, type 7 is subserosal pedunculated, type 8 is other cervical, etc. The appearance would be made out with the ultrasonography. The typical appearance ultrasonography of all these 8 types would be submucosal. The appearance would be seen. So ultrasonography is one of the relevant investigation which to confirm the diagnosis of fibroids. Accuracy and specificity of ultrasonography is very high, that's around 90%. So chances of missing a fibroid under ultrasonography is less frequent. The other investigations are MRI images. MRI images again as per the types, type 1, 0 to type 8. The same are seen over here in the selected images. It's for the academic purpose. All that would be, they would be able to, like MRI would be in a better position to locate the fibroid and its relationship with either serosal or the endometrial layers, and that gives you the clear idea. Approach to the uterine fibroids would be the standard protocol, the guideline would be, if the patient is asymptomatic and the uterine fibroids are just diagnosed due to some other reason when you have done it, then there is no need of any intervention. The better is follow up, continue to follow up, see whether the size is increasing or not. If the patient is having a symptomatic, and if the patient is in the postmenopausal stage after the menopause, then endometrial biopsy is necessary, because the chances of some malignant complications are there in the postmenopausal phase, and the patients may presenting with the bleeding in the postmenopausal phase. There could be other underlying pathology, and their hysterectomy with or without salpingo-oophorectomy, or simply myomectomy. Myomectomy is only the mass is removed but the uterus is saved. These are the two options. If the patient is in a premenopausal stage, then if the patient prefers to keep the fertility, maintain the fertility, now there again, well, in the premenopausal phase, patients presenting with these issues, fibroids, Some of the patients may wish to maintain their fertility, and the patients may not bother about the fertility but have to preserve the uterus, and the patients do not wish to preserve the fertility or uterus. These three categories. In those patients where the patient doesn't bother about the fertility or uterus, surgical therapy of either uterine artery hysterectomy or myomectomy is the one choice, or the other options which are now available are uterine artery embolization or MRI guided ultrasound surgery. Ultrasound surgery also are suggested, but most of the times what we generally prefer is hysterectomy or myomectomy. Patients who prefer to maintain the uterus but they are not bothered about the fertility, the lenosterol inducing hormones or releasing hormones could be given, gonadotropin could be given, by which the fibroid doesn't go, but the fibroid would remain as such, but doesn't increase and doesn't result in any other complications. Size may just slightly regress. In case of those who prefer to maintain the fertility, non-steroidal anti-inflammatory drugs or oral contraceptives to reduce the bleeding and reduce the symptom. These are the options which are usually suggested. From our routine clinical point of view, again from Ayurvedic approach point of view, I don't say that there would be any treatment which can dissolve the fibroids, but the usual drugs like Kantanarabugulu, Chandraprabha and Ushiras were given for a long time can result in a better clinical course. The complications would be lesser. I have seen many patients who may also have a normal conception and pregnancy also with relatively larger fibroids, and the fibroids could be handled during the cesarean section if necessary. The medical treatment options, there are now many, but none of these medical treatment options in the contemporary science, they have a perfect outcome, and the options are either gonadotropic releasing hormone agonists, which gonadotropin hormones which could be given, and there it has to be given preoperatively to decrease the size of the tumor. It reduces the blood flow, and even surgery also would be easier if they are given, but they cannot be used to cure the condition, and there may be in due course of time it may result in the bone pathology, the osteomalacia changes can occur, osteopenia changes may occur as such, and these are not very popular, but still they are often used in the contemporary medicine. Then levonorgestrel releasing hormone intrauterine system, which is now becoming somewhat popular among the modern gynecologists. We do not use that, and I think Chandraprabha is much better than that from that point of view. It can result in the disadvantage of intrauterine bleeding, and if the patient is having some contraceptive devices, it may get expelled as such. That's one of the issues. Then non-steroidal anti-inflammatory drugs also are often used, and they may reduce the pain only, but there will be no effect on the volume or gastrointestinal effects. No change in the volume, no change in the situation of the fibroid uterus. Oral contraceptives, then they do not decrease the fibroid volume at all. The only advantage would be they may reduce the symptoms of bleeding, that bleeding could be reduced. Progesterone receptor modulators also often prescribed, rarely prescribed, and they may produce more severe symptoms like adverse effects like headache, breast tenderness, etc., and hence they are not really used as such. Then tranexamic acid also is often used, and this also has a very limited uses, like it doesn't decrease the fibroid volume at all. So very few of the medical treatment from the contemporary side may reduce the fibroid volume, and our treatment, Ayurvedic treatment, also may not reduce the fibroid volume as such, but complications can be effectively managed, and there is no need of surgery. And I usually have a criteria, like if the fibroid size is more than 10 centimeter, then irrespective of that whether there is a bleeding or not, the hysterectomy would be required. But if it is less than that, and if the patient doesn't have a bleeding and the patient has a lesser chance of conceiving fertility later, that's the age of above 40, 50 or so on. Usually our medical management would be enough, there is no need of surgery unless the patient opts for it. But if there is a intractable bleeding and such conditions, surgery would be necessary. Among the surgical therapies, again, hysterectomy, of course, the adverse effect is once you have removed the uterus, there will be no more pregnancy or the issues. Of course, it also can result in the issue, the later complications. One of the recent trends, new trends which are coming up is intrauterine arterial embolization, where the clotting substances are injected into the uterine arteries, which can result in a shrinkage of the lesion, and it's also considered as a OPD procedure, daytime procedure, but available only in very sophisticated hospitals and costly also. But with that, the recurrence rate is more than 70% after 30 months. That's the issue. With this, we will conclude today, and we in the next session we will take up male sexual organ related tumors. If there are any questions, right, okay, we will conclude today.